Good morning, everyone. Today, we're diving into distribution and service accessibility in reproductive health, essentially the place in the marketing mix. Think of it as how we make sure patients can actually reach and use health services. Even the most effective contraceptive, vaccine, or health counseling session is useless if patients can't get to it. Today, we'll explore strategies to make services reachable, convenient, and acceptable. Let's start with what you should be able to do by the end of this session. By the end of this lecture, you will be able to evaluate, understand why place is so critical in reproductive health marketing, both physical and digital availability. Analyze, examine different distribution strategies, including how facility locations, patient behaviors, and access patterns influence service uptake. Innovate, identify creative ways to reach patients through telemedicine, community health workers, or school programs to expand access and equity. So what exactly does place mean in this context? Place isn't just a building or a clinic. It's every effort we make to get reproductive health services to the people who need them. It involves balancing convenience with practical and social barriers. For example, even if a clinic is nearby, social stigma or lack of transport can prevent patients from accessing care. Key components of distribution include physical facilities, include hospitals, clinics, and mobile health units where services are delivered. Human intermediaries, community health workers, and outreach teams who bring services closer to patients, especially in hard-to-reach areas. Digital platforms, including telehealth apps, online consultations, and e-prescriptions, enable patients to access care remotely. The main goal is to reduce barriers and the travel burden for patients, so services are both accessible and acceptable. Next, let's explore the main dimensions that influence access. Even if services exist, patients might face different barriers. Geographic access. How far is the clinic? Are there reliable transport options? For instance, a woman in a rural village may spend hours traveling for prenatal care. Financial access. Can patients afford the cost of travel or lost income from taking time off work? Access is more than free services. It includes the hidden costs of getting care. Psychosocial access. Is the service discreet? Will patients feel judged? For example, adolescents might avoid going to clinics for sexual health services due to fear of stigma. Given these challenges, distribution strategies vary between urban and rural areas. In cities, access is usually less about distance and more about convenience, anonymity, and integration into daily routines. Mixed integration. Clinics near transport hubs, shopping centers, or workplaces make it easy for patients to combine visits with other activities. Extended hours. Evening or weekend slots accommodate working adults who cannot visit during regular business hours. Anonymity. Busy locations provide cover for patients seeking sensitive services, like STI testing or abortion care. In rural areas, strategies must address longer distances and weaker infrastructure. In rural areas, need creative approaches because patients may live far from clinics. Mobile clinics, rotating schedules bring care directly to villages, reducing the travel burden. Hub and spoke. Central hospitals, hubs, support smaller satellite posts, spokes, creating a network that improves reach and efficiency. Task shifting. Training local midwives or CHWs to provide basic reproductive health services ensures patients can access care locally without traveling long distances. A powerful, real-world example of this is maternity waiting homes. In rural Ethiopia and Uganda, many women die during childbirth simply because they can't reach a hospital in time, the so-called delay in reaching care. Maternity waiting homes solve this by providing lodging near hospitals for high-risk women in the weeks before delivery. By shifting the place from home to a medical environment, women are more likely to receive timely, skilled care, significantly reducing maternal mortality. But distribution isn't just about one facility. It's about connecting multiple points of care. Distribution works best as a connected network rather than a single point of care. Community level, CHWs identify and triage high-risk patients early, for example, spotting preeclampsia in pregnant women. Primary care, stabilization and initial treatment occur here. Tertiary care, complex procedures such as C-sections or specialist interventions are performed in hospitals. The key is minimizing leakage, patients who fall out of the system and fail to reach the care they need. So how can we optimize these referral networks? Successful referral networks rely on coordination and support systems. Identification. Midwives and CHWs follow standardized protocols to flag high-risk cases early. Communication. Hospitals are alerted in advance using radios, SMS, or mobile apps. For example, Patient X arriving for emergency care. Transport. Ambulance vouchers or contracted taxis ensure timely transfer. Reception. Fast-track admission lanes reduce waiting times for referred patients. Next, let's explore how digital channels are revolutionizing distribution. Digital platforms are transforming access. Patients can now consult doctors via apps, receive prescriptions electronically, and even get medications delivered to their doorstep. Digital distribution is particularly effective for young adults, urban populations, and those living in contraceptive deserts, making care more discreet, fast, and convenient. An excellent example of this is the direct-to-consumer model. Companies like Nurx, RO, and Lemonade allow patients to access reproductive health services without visiting a clinic. Asynchronous access. Patients complete online forms at their convenience, and doctors review remotely. Mail delivery. Medications and test kits are delivered to the patient's door. Privacy. Patients avoid public visits and potential embarrassment. The result is high uptake among young adults and people in areas with limited access to reproductive health services. However, in many communities, human distribution channels are still crucial. In several markets, the distribution channel is a person rather than a building. The Promotora model. Trusted community members educate residents, provide referrals, and sometimes deliver contraceptives like injectables directly to homes. CHWs can navigate cultural and social barriers that clinics cannot, increasing uptake and trust. Schools also serve as an essential distribution channel for adolescents. Schools are ideal for adolescent reproductive health because they are trusted environments. Education and marketing. Comprehensive sexual education programs increase awareness and demand. School-based health centers, or SBHCs, provide on-site counseling, STI testing, and reproductive health services. Being in a familiar, trusted space encourages adolescents to seek care, compared to intimidating or sterile clinics. We need metrics to see whether our distribution strategies are actually working. Key performance indicators, or KPIs, help evaluate distribution success. Travel time analysis. What percentage of the population can reach services within 1 hour? Door-to-doctor time. Total time from leaving home to receiving care. Conversion rates. How many referred patients actually reach the hospital? Equity index. Are services accessible to low-income and marginalized populations? Finally, let's open the floor to questions. What challenges do you foresee in implementing these distribution strategies in your communities? Which channels, physical, human, or digital, would be most effective? Remember, distribution is about ensuring the right service reaches the right person at the right time in the most accessible and acceptable way possible.